All right, good morning, everyone. It is the top of the hour, so let's get started. It's my pleasure to welcome you all to today's Region 4 Project Echo session from the Emory University School of Medicine Serious Communicable Diseases program, run in conjunction with the Southern Regional Disaster Response System and the National Emerging Special Pathogens Training and Education Center. My name is Gavin Harris. I'm an adult infectious diseases and critical care physician at Emory University, the Director of Education and Outreach here at the SCDP, and your host for today. Before we begin, please know that we will be recording this session, and your data, while used for informative purposes, will be kept confidential. For those unfamiliar, ECHO is an acronym standing for Extension for Community Healthcare Outcomes, founded by the University of New Mexico. It's designed to disseminate and amplify best practices in a collaborative and interactive manner. And if you're interested in participating in future sessions, please reach out to us. Details will be at the end and on our website. As always, if there are any issues during the webinar, please send us an email or type in the chat. And if you would like to ask a question during the session, please type it into the Q&A feature. We'll do our best to answer questions in real time, and we'll discuss as many questions live as we're able. If we do not get to all questions, we will post a recap addressing those topics on our website when the recording to this session is available as a podcast next week. These sessions are accredited for continuing education credits by the AMA and the ANCC. Credit can be obtained for attendance upon completion of a survey at the end of this session. The presenters and the planners of this session have no financial conflicts of interest to disclose with ineligible companies. And here is today's agenda. As always, we will start with the Region 4 SITREP. This will be followed by our case and didactic presentations with moderated Q&A to follow. And now it's my honor to introduce our guests for today, all of whom have participated on our program before, and all of whom I am proud to call close colleagues. Our case and didactic presenter for today's session is Dr. Tim Uyeki, Chief Medical Officer of the Centers for Disease Control and Prevention Influenza Division. Dr. Uyeki is arguably one of the world's top experts on influenza viruses, having worked on the virus both domestically and abroad at CDC since 1998. He has extensive field experience and has worked at many levels with various governments to combat respiratory viruses, and is the co-investigator and founder of the Severe Acute Respiratory Infection Preparedness Clinical Research Network, among many others. Next, to provide us with a regional public health perspective, is Dr. Amanda Feldpausch, Deputy State Epidemiologist and One Health Epidemiology Director at the Georgia Department of Public Health. Dr. Feldpausch, a veterinarian by training, oversees One Health epidemiologic activities in Georgia, including the state detachment of the National Wastewater Surveillance Program and the Respiratory Disease Epi Unit. She currently serves as a co-lead for emerging health threat responses in epidemiology and leads the H5N1 response. She's worked with the Department of Public Health for over 10 years, serving in a variety of leadership roles for various emerging special pathogen responses. And lastly, I'd like to welcome back Dr. Matt Lynham, Associate Professor of Pediatric Infectious Diseases at the Emory University School of Medicine and the Hospital Epidemiologist for Children's Healthcare of Atlanta, or CHOA, Scottish Rite Hospital. Dr. Lynham is also the Medical Director of Outcomes at CHOA. His special focus is on the prevention of healthcare-associated infections and has designed and led many quality improvement training courses to provide healthcare workers with the necessary skills to improve the quality and safety of pediatric care, his passion. Welcome to you all. And now to place this session in context, the Emory University Serious Communicable Diseases Program, in conjunction with the SRDRS, puts together situation reports on special pathogens of concern for our region, HHS Region 4. These SITREPs are typically published on our website, social media channels, Emory Department of Medicine YouTube channel, and listservs. Here is the current HHS Region 4 Special Pathogen SITREP. First, to Saudi Arabia, where the WHO was notified on the 5th of September of a case of Middle East Respiratory Syndrome coronavirus, or MERS. The patient, a middle-aged man, was admitted to a hospital, supportively treated, then left prior to the diagnostic results returning and traveled to Pakistan. As per the international health regulations, the patient was located in Pakistan and transferred for strict isolation, and close contacts were quarantined. No additional cases were reported, and the patient recovered. He was not a healthcare worker and had not had contact with camels. This brings the total case count for MERS in the in the Saudi Arabian area to 5 cases for the year, with 4 deaths. Now to Crimean Congo hemorrhagic fever. On the 13th of October, the Iraqi Ministry of Health reported that for 2024, thus far, there have been 211 confirmed cases with 26 deaths, a case fatality rate of 12%. Additionally, Pakistan has reported 34 confirmed cases and 9 deaths, a CFR of 26%. Likely, these are both undercounts, but we do expect numbers of CCHF to decrease as the end of the month nears and pilgrimage and animal processing seasons wind down. And now to West Africa, where the most recent data on Lassa fever was released on the 6th of October. Since our last SITREP, almost 1 month prior, in Nigeria there have been 20 new confirmed cases and 2 new deaths, bringing the total for the year to 1,025 confirmed, 8,484 suspect, and 10,235 probable cases, with 174 fatalities. Similar to last year, this equates to a CFR of 17%. Case numbers all continue to progress in a reassuring pattern and continue to steadily decrease. Now moving to Rwanda and to one of the largest Marburg virus outbreaks on record. As of earlier this week, the Ministry of Health of Rwanda reported 62 cases and 15 deaths, and only 1 patient currently admitted to a hospital for treatment. There's been no evidence of community transmission. All cases have been linked to 3 hospitals in the capital, Kigali. 80% of those cases have been in healthcare workers, and there have been no new cases since the 15th of this month. The case fatality rate has been 24.1%, far below the average 50 to 80% in historical Marburg virus disease outbreaks. Rwanda has mounted a robust response to the outbreak, which has likely contributed to such success, vaccinating over 1,000 people with a vaccine distributed from the United States and treating patients with monoclonal antibodies and remdesivir. In addition, their public health responses have included contact tracing, quarantining, limiting in-person schooling, and hospital visitations. Notably, in a first for the African continent, 2 patients who had developed multisystem organ failure were successfully extubated and discharged from hospital. Genomic sequencing indicates that the source of this outbreak was likely spillover from a bat, as the index patient prior to the development of symptoms had contact with cave-dwelling bats. And lastly, to our own country, where this week, in regions 9 and 10 on the West Coast, more human cases of H5N1, or highly pathogenic avian influenza, have been confirmed in California and Washington. Just yesterday, the California Department of Public Health reported 2 cases in addition to a case reported earlier this week from exposure to dairy cattle. The state's total this year is thus 15. Additionally, 4 presumptive positive cases in poultry workers in Washington state are awaiting confirmation by the CDC. If confirmed, they would bring the national total this year to 31. All patients have been symptomatic but are mild cases. And in important news, Quest Diagnostics has been awarded several contracts by the CDC to support testing and lab readiness for H5 influenza using respiratory or conjunctival specimens. This testing, obtained through a prescription, would alleviate the sending of samples through state or public health labs for avian influenza identification and should be available by early next month. Finally, there have been no reports of other suspect or confirmed patients with special pathogens of concern in Region 4 at this time. For more resources, visit us on the web at scdu.emory.edu. And now, as always, before we delve into the main topic at hand, I wanted to first pose some interactive poll questions to our audience to gauge our base comfort level with this topic. They should be up on your screen. If you could please vote now. The first question, how confident do you feel about utilizing the processes of identifying, isolating, and informing as it pertains to encountering a person with suspected case of H5N1? And 2, how knowledgeable do you feel about the clinical management of a person with a suspect or confirmed case of H5N1? Please vote now. All right, and if we could have the results up on the screen, please. So it looks like we have quite a range in terms of the first question, from not at all confident to fairly confident. So our our panelists certainly have their work cut out for them, which is fantastic. And then there's also quite a range in terms of the second question, in terms of management. So with that, let's begin. I'll turn it over to Dr. Yeki.
Thanks, Dr. Harris. just want to confirm, can you see my full screen?
Yes, we can. Thank you.
Okay, great. Thanks for the opportunity to speak, and good morning to everyone. I'm going to give an update on H5N1. Um, my disclosures, I have no disclosures to report, and my disclaimer is the findings and conclusions are those of mine alone and do not necessarily represent the official position of the CDC. So what I'm going to do is try to give an overview. This is a highly pathogenic avian influenza A H5N1 virus, and there are specific molecular and pathogenicity criteria for designating what is a highly pathogenic virus versus a low pathogenic virus, and this simply pertains to poultry. Um, these viruses infect the respiratory and gastrointestinal tracts of birds. They're associated with high mortality, and in poultry, particularly rapid and high mortality. Like all avian influenza A viruses and all influenza A viruses, they continue to evolve. They can evolve through minor mutations. They can also evolve through genetic reassortment, swapping of genes to create new viruses. And we classify the evolution of these viruses into different genetic groups or clades. So the first time this came to public health importance, the recognition that this virus could go directly from a chicken to infect a person and actually kill a person was during the Hong Kong outbreak in 1997. And since 2003, the reemergence, there have been these sporadic human infections worldwide. And to date, the most predominant clade of virus are these 2344B viruses. They're spread by wild birds. They do infect poultry, causing commercial poultry outbreaks or outbreaks in backyard poultry or small flocks. But there's also been many, many local wild bird species involved, including um, all the way up to raptors. There's been spillover to terrestrial as well as marine mammals, and this includes wild terrestrial mammals, but also farm mammals. Um, most of these infections are fatal, but not all. In the US, we first detected this virus in wild birds at the end of 2021. There have been poultry outbreaks in North America since February of 2022, and this is ongoing. And to date, there have been more than 100 million commercial poultry or backyard birds that have been affected, as well as many species of wild birds, and this is in most states. But what is new is the emergence um, or the identification this year that this virus can infect livestock, and that's the virus has been documented in baby goats and alpacas, and notably the ongoing multi-state outbreak, more than 300 dairy cattle herds in 14 states. As of yesterday, it was 333 dairy cattle herds with confirmed H5N1. That number will continue to go up. The state that is currently most affected is the number one dairy producing state in the US, and that is California. So the first time we learned about human infections with this virus was during the Hong Kong outbreak in 1997, 18 cases and 6 deaths. Both children and adults were impacted. There were a lot of febrile upper respiratory tract infections in the pediatric cases, but also fatal outcomes. In the adults, there were some fatal pneumonia cases and critical illness. We didn't hear much about this virus until the reemergence in late 2003, actually early 2003. There were some cases of H5N1 in a family from Hong Kong that had gone into southern China. But at the end of 2003, continuing into 2004 and thereafter, human cases, sporadic cases in Southeast Asia and China. And then since 2005, cases have been identified in other regions of the world, including North America. Most of these cases have been sporadic cases with pneumonia. Most case finding is in hospitals, so it's a bit biased towards severe disease. Most cases have been in young adults, but some pediatric cases. And then what I've listed here in blue are some of the different clades of virus that are circulating and the range of illness. So there is endemic spread of these clade 232 One C viruses in the Mekong Delta, and in last year and this year, there have been sporadic cases in rural villages in Cambodia, 16 cases and 6 deaths associated with exposure to backyard poultry that were sick or died. Um, there's also one case in an Australian child who had traveled to India and returned to Australia, became critically ill. That virus was related but distinct, the clade 2321A virus. And then there have been cases of 2344B viruses with critical illness in Chile, China, and Ecuador, including one fatal outcome in China. And then I'll just mention the cases of in the US. So this is an epidemic curve of all the cases to date as of yesterday. This number is going to continue to increase slightly as new cases are detected, including in the US. But 944 cases reported from 24 countries with 50% case fatality proportion. And what you see is after the large outbreak in Egypt in 2015, a drop off of cases, and then over the last 2 years, increasing number of cases reported by 9 countries. So in the US, we've had 30 cases to date as of yesterday, 29 of these reported in 2024. No secondary transmission has been identified. Oseltamivir treatment was administered or offered to all of these cases. It was declined by a few who actually had recovered by the time of their diagnosis, and oseltamivir has been given as post-exposure prophylaxis for close contacts. 10 of these cases were associated with poultry exposures. One of these cases was in April of 2022. This person was depopulating poultry, only reported fatigue, no other symptoms. My personal opinion is that person wasn't actually not truly infected. However, in July of this year, there were 9 cases of conjunctivitis. A few had acute respiratory symptoms as well. These occurred in poultry workers depopulating poultry at 2 different commercial poultry farms in Colorado. 19 cases to date associated with dairy cattle exposures in 4 states. There could be a 5th state in the near future, but 4 states to date, all associated with this ongoing spread of the virus among dairy cattle herds. And 18 of the 19 cases had conjunctivitis. Some had other respiratory symptoms. And then there was one case patient who only had acute respiratory symptoms. Again, none of the above were hospitalized. They were, in my opinion, all clinically mild cases, and they were all treated or offered oseltamivir treatment, and they all recovered. There was one case who was hospitalized. It was a retrospective diagnosis. The source is unknown. This is a person who had no exposures to animals or sick persons. They were actually had a syncopal episode. They were admitted for the workup. It was patient reported chest pain, diarrhea, fatigue, had a number of chronic medical conditions, no respiratory symptoms. Chest imaging was negative. They were hospitalized for 3 days. As part of the workup, influenza testing was done. Influenza A was positive. They were started on an oseltamivir treatment in the hospital. Droplet precautions were implemented. They recovered and were discharged, and the diagnosis was made after the person had already been discharged. It's a real puzzler. We don't know how to explain this case, but the good news is there's no evidence of secondary transmission, including in this state, and was in Missouri. So how do people get infected? What are the risk factors? Since 1997, overwhelmingly, the risk factor has been exposure to infected poultry through direct or close unprotected exposure, typically to sick or dead backyard poultry in rural areas, but also visiting a live poultry market. Small number of cases were exposed to infected wild birds, 2 clusters in Azerbaijan. They found dead wild swans. They took the feathers off. 4 out of 7 cases died. There are cases with no known source of infection. I mentioned the case in Missouri in August of this year. Another example is there was a return traveler to Canada who had spent 4 weeks in Beijing, China in December of 2013. was ended up being admitted for pneumonia and meningoencephalitis, unknown source of exposure, no animal exposures supposedly. And then we have to add this potential for sporadic mammal to human transmission because of the first cases of dairy cattle to human transmission in 2024 in the US. There's no evidence of this virus in dairy cattle outside the US, although it is certainly an area of um, important concern and surveillance. I'll just mention limited non-sustained human to human transmission has been documented. Um, it's an epidemiologic conclusion among secondary persons who have had prolonged unprotected exposures to a symptomatic case patient, either prior to that patient being admitted to the hospital, but it's also included. It's also occurred in the hospital setting. Again, sick family member transmission to another family member in the hospital. This is the argument for good infection prevention control and PPE, recommended PPE for not only healthcare personnel, but also the family members of the patient. It's not been reported since 2007. It's always a concern, and therefore we always need to investigate every single case and particularly follow the close contacts. And we are recommending oseltamivir post-exposure prophylaxis to close contacts of cases in the US. So the incubation period is a mean of about 3 days with a range up to a week. Typical presenting findings in those with mild respiratory illness are typical acute respiratory illness, sort of uncomplicated influenza, with the exception that abdominal pain and gastrointestinal symptoms may be present in up to about a quarter of patients, particularly diarrhea. In patients with conjunctivitis only or conjunctivitis and respiratory illness, the conjunctivitis symptoms can occur as short as 1 day after exposure. For example, we know this from a few case patients in the US who were splashed in the face, in the eye, with milk while milking a cow. In those who progress to severe pneumonia, they typically progress about 6 days after symptom onset, and they present with typical signs and symptoms of pneumonia, radiographic findings of bilateral pneumonia, and the classic clinical laboratory findings are leukopenia, lymphopenia, mild to moderate thrombocytopenia, but this is not always present. Pneumonia is the most common complication with progression to respiratory failure and ARDS. Community-acquired bacterial co-infection is very rare. That is in contrast to seasonal influenza, where it's much more common. Other severe complications include acute kidney injury, cardiac failure, sepsis, shock, DIC, multi-organ failure. Very atypical complications are encephalitis or meningoencephalitis with pneumonia, Rye syndrome with salicylate exposure in a kid, spontaneous miscarriage and vertical transmission has been documented in an autopsy study. How might people be potentially exposed? Well, in the US, it's been occupational exposure, people with close, prolonged, unprotected exposure to infected animals, including livestock, or potentially to environments contaminated by infected animals. These typically include dairy farm workers and poultry workers. It is possible that slaughterhouse workers, milk processing facility employees, veterinarians, and veterinary assistants could potentially be at risk. To date, it's just been the dairy farm workers and the poultry workers. And of course, we should always be concerned about potentially unprotected exposure to a symptomatic person with H5N1 virus infection, limited human-to-human transmission. So testing in outpatients. So if H5N1 virus is suspected on the basis of clinical findings as well as history of exposure, then clearly implement recommended infection prevention control precautions and use recommended PPE. So in those with respiratory symptoms, collect a nasopharyngeal swab and a combined nasal and throat swab specimen. Put those specimens into separate tubes of viral transport media. The patient only has conjunctivitis, collect a conjunctival swab and a nasopharyngeal swab. Put them in separate tubes of viral transport media. get these specimens to a public health laboratory. That could be at a county, it might be at a metropolitan public health laboratory. It's typically at a state public health laboratory. I want to make the point that influenza tests that are widely available in clinical settings do not specifically identify H5N1 virus. They cannot differentiate H5N1 virus from seasonal influenza A viruses. And so basically, you need to perform subtyping of influenza A viruses for H1 and H3. And if those are negative, but influenza A is positive, you need to test for AH5 and using the CDC real-time assay. So in those who are hospitalized with lower respiratory tract disease, again, implement recommended infection prevention control measures, use N95 filtering face piece respirator, eye protection gown and gloves, collect the same upper respiratory tract specimens as I mentioned for patients with mild upper respiratory tract disease, but also consider collecting sputum and lower respiratory tract specimens if the patient is intubated, an endotracheal aspirator, a bronchoalveolar lavage fluid specimen. And the reason is that patients have been documented to clear virus from the upper respiratory tract, but have ongoing viral replication in the lower respiratory tract. And that's where the diagnosis was made by sampling the lower airways. Just to mention antiviral treatment, we have no randomized controlled trials of antivirals for H5N1 patients. We have limited observational data, particularly from patient registries. And the bottom line is that oseltamivir treatment versus no treatment, as well as oseltamivir treatment starting early, such as in the first 2 days after symptom onset versus later initiation of treatment, is associated with lower mortality. And therefore, we do recommend early initiation of oseltamivir treatment, including empirically if H5N1 virus infection is suspected. We have had no evidence of de novo oseltamivir resistance in patients who are infected in the US or worldwide in 2024. So in outpatients with clinically mild disease, we recommend standard dosing twice daily for 5 days. We have no data for baloxavir. For lower respiratory tract disease, we do not know the optimal dosing or duration, but certainly longer treatment should be considered. You could also consider higher dosing. There is prolonged shedding with more severe disease, and emergence of oseltamivir resistance has been reported during or after treatment. And in the figure there, this is from Vietnam patients back in 2004 and 2005, 3 patients who had oseltamivir resistant H5N1 virus infection. They maintain high levels, and those are fatal outcomes. Whereas in the blue, those are patients with oseltamivir sensitive virus. Viral levels decreased over time with treatment, and those patients survived. So oseltamivir resistance is a concern, and that leads to the consideration of combination treatments such as oseltamivir and baloxavir. Basically, in hospitalized patients, the bottom line is isolate the patient in an airborne infection isolation room with negative pressure, follow recommended IPC measures, and use recommended PPE, start oseltamivir treatment, but care is really supportive care of complications, advanced organ support, and very good critical care. In terms of adjunctive therapy, avoid moderate to high dose corticosteroids because they're associated with prolonged viral shedding, and they may increase the risk for ventilator associated pneumonia and death. Unfortunately, we have no data for H5N1 or for seasonal influenza for other immunomodulators such as the IL-6 receptor blockers and the Janus kinase inhibitors, such as been shown in clinical trials to have clinical benefit for severe COVID-19. We need the data. So with that, I'm going to stop and pivot to a case presentation, sort of apply what I just presented. So the patient is, you're in clinic, and the patient is a 37-year-old male who presents with a 3-day history of bilateral eye discomfort, photophobia, sore throat, headaches, feverishness, non-productive cough, myalgia, and diarrhea. The patient reports that they work at a poultry farm in Georgia, and of note, high-path H5N1 virus has not been identified in poultry or dairy farms in Georgia in 2024. Patients' past medical history is unremarkable, but they are not up to date on adult immunizations. They have not received the 2024 COVID-19 vaccine or the 2024-2025 influenza vaccine. They have no current medications. They're not a smoker. Findings on exam, vital signs are unremarkable. Pulse oximetry is 96% on room air. Pertinent findings on physical exam, bilateral palpebral tarsal inflammation. There is right eye subconjunctival hemorrhage and right eye purulent drainage. The throat is erythematous without exudates. On chest exam, there is good air exchange in the lung, slightly diminished breath sounds bilaterally, but a non-focal exam. So, differential diagnosis, think about that. I just threw out some things that you might think about. Community-acquired respiratory virus infection, what is going on in the local community in terms of circulation of seasonal respiratory viruses or SARS-CoV-2. What about psittacosis in a poultry worker with these findings? What about H5N1, even though H5N1 has not been identified in dairy farms or poultry farm in Georgia? What about group A strep? What about any of the above with bacterial conjunctivitis? So as you're thinking, this clinician who sees the patient sends off a rapid SARS-CoV-2 antigen test. It's negative. Rapid influenza AB antigen test, it's negative. Rapid group A strep test, it's negative. Decides to do a chest x-ray just because of non-specific findings on pulmonary exam. Chest x-ray is basically normal. So what are you going to do? Well, this clinician sent the patient home, prescribed erythromycin ophthalmic ointment. End of story. Maybe, maybe not. Patient returns 2 days later with a worsening cough. Then there was some language issues. A new history is elicited. This individual was actually participating in poultry culling work at a commercial poultry farm in another state. Almost all the chickens died. I was helping to dispose of the dead chickens. The patient returned 1 day before the first clinic visit. Physical exam, vital signs are unremarkable except for pulse oximetry of 94% on room air. Pertinent findings on physical exam, resolving bilateral conjunctivitis, resolving right eye subconjunctival hemorrhage, no drainage, no discharge. Throat is erythematous, no exudates. Lungs, good air exchange, but slightly diminished breath sounds bilaterally, still non-focal exam. What do you think about that? Well, the clinician repeats all the tests again. Rapid SARS-CoV-2 antigen test negative. Same thing with the rapid influenza test. Same thing with the rapid group A strep test. Decides to get a chest x-ray because of slightly decreased pulse oximetry. Mild bilateral interstitial infiltrates, but the patient is breathing comfortably. The clinician decides, given the history, these findings, refers the patient to the local public health department for suspected H5N1, consults with the local health department in the state and looks at CDC recommendations, collects conjunctival swabs, an NP swab, combined nasal throat swab, sends it specimens to the Georgia Department of Public Health laboratory for influenza testing and subtyping, prescribes empiric oseltamivir treatment. Local public health is going to do close monitoring, question of referring the patient to an emergency department, and local public health is going to follow up on the testing results and household contacts. So take-home points, rapid influenza tests have low sensitivity to detect seasonal influenza A and B viruses and to detect novel influenza A viruses in respiratory specimens. and cannot specifically identify H5N1 virus. So if you suspect H5N1, you should contact your local and state public health department. You should start empiric oseltamivir treatment as soon as possible, isolate the patient, collect the recommended clinical specimens, and get them to a public health laboratory, and monitor the patient for clinical worsening and identify and monitor their close contacts, and start oseltamivir post-exposure prophylaxis if the patient tests H5 positive. There's a lot of resources on the CDC web pages. Here are some of them, and I'll just stop there and turn it back over to Dr. Feldpash and Dr. Harris. Thank you.
Thank you so much, Dr. Yucky, for that fantastic overview and for that case presentation. Now we're going to move to our regional public health perspective with Dr. Amanda Feldpausch, and we'll get her slides up on the screen presently. A reminder while we're doing that, if anyone has a question, please type it in the Q&A feature, and we will attempt to get to all questions in real time. All right, we can see the screen. Dr. Feldpausch.
Thank you all. And I had a little trouble with the slides on my own, so I'm going to say next slide. We can keep going. And next one. So some of the overarching concerns. So we've had a great perspective of clinical medicine and some of the impacts to human health. One of the things we think about in public health is a One Health approach. So this may affect both our human populations and our animal. When we think about H5N1, we think about overarching concerns, and that does not take away from any of our activities, but it just helps us to kind of think about how this may affect groups across the board. So there is a huge economic impact to our H5N1 outbreak right now on our agricultural industries. There's been over 100 million birds impacted within the commercial and backyard flock industry. Poultry depopulation is a significant impact to our agricultural community. There's food safety and perception issues. There's not a lot of impact to safety, but perception is huge. And again, speaking from my perspective as Georgia Department of Public Health, we are the top poultry producing state in the nation. So that is something that we are highly concerned about. From the human health side, we are also concerned about the pandemic potential of this. It is the worst case scenario, but it's not likely. And I'm going to give some denominators to some of the things that have been talked about previously that will help to talk about that a little bit further. But any animal flu virus that develops the ability to infect people can evolve into a novel virus that can spread person to person, and that's our greatest concern for human health. Next slide. And next one. So I'm going to skip over this because we've already talked about it and go to the next slide. So one of the things we like to point out from the public health perspective and thinking about, again, that One Health approach and our agricultural colleagues is there have been detections of high-path avian influenza in mammals for quite some time. This is a quick map to look at that. This came out with the detections in cattle and a perception, again, a public perception that there was a novel situation of having it identified in animals or in agricultural congregate areas other than poultry, but it's not new to us. And it's just something to keep in mind when we're thinking about this situation as a whole. However, when we're talking about animals that have close contact with humans, like cattle in livestock situations or like poultry in these commercial poultry situations, we're talking about closer human to animal contact, which again gives us that bigger concern for that pandemic effect. Next slide. So one of the things that challenges us in public health is the difference between poultry and bovine H5N1. So with poultry, this spreads rapidly in poultry. It causes severe respiratory infections, high mortality, and the whole flock is depopulated. The difference with bovine, it's not fatal typically. Cattle can recover in a few weeks. Symptoms develop slowly. They may be asymptomatic. The reason this is important to us when we think about human interaction is we have longer ongoing exposure. With poultry situations, depopulation is done fairly quickly, and the risk of exposure is removed at that point. With bovine or cattle infections, we have prolonged exposure to humans. During this time when these cattle are sick, they need people caring for them. Although they are typically wearing PPE once that infection is identified, we still have the potential for longer term exposure. So this is a concern for public health and for monitoring. Next slide. So the closer and continued exposure from infected cattle to people is a huge concern for us. Like I just mentioned, we may see people with more exposure to them over time. It's also, again, more challenging to define the end of exposure period for human monitoring. Something to call back to the previous presentation on is thinking about if you're concerned about exposure, and in that case example, the person had done some depopulation out of state. Typically, folks that have worked either in depopulation with poultry or in response to cattle responses in other states are reported to your state, local, and local public health departments. So they will be knowledgeable about those persons in monitoring and looking for potential for symptoms and other concerning signs in them. But there is a challenging factor to defining the end of exposure for human monitoring in these cattle events. Next slide. So again, as we've talked about before, some of these numbers have been updated as early as this morning. So there's now, as of today, 339 cattle herds in 14 states. In the last 30 days, there's been 101. I know this says 112, but that's a moving window. It's still 2 states, California and Idaho. But we are still monitoring this and also concerned about folks that have close contact with these cattle. Next slide. So I have this slide in here, and I think it's, I'm not going to belabor it because we've already talked about numbers, but it's a good example. The slide is from just a few days ago, but these numbers have changed significantly. As was spoken about earlier, there's been increases in numbers in California. We also have some presumptive positives in Washington state that we're waiting on. And then again, there was discussion about the one Missouri case with unknown exposure. Mostly what I wanted to point out here is to think a little bit about denominators, which I believe we have on the next slide. If not, we'll go further from there. Next slide, please. All right, so no human-to-human transmission has been detected, as was previously discussed. Beef cattle and swine have not been detected, but that is a concern for us in our agricultural settings. But we have had farm cats affected, which is something, again, that affects us from a public health standpoint because we do have humans with close contact to them. Next slide. So should we worry about a pandemic? From a public health standpoint, we want to think about what is the risk for the general public. It remains low. Again, I have a slide a little bit later talking about denominators when we're talking about these human cases. What we're most concerned about are farm workers with close prolonged exposures to infected animals or their environments. They do need PPE. What we do understand, and something that's we just have to consider, is that PPE, although it's recommended and although people do understand the need for it, sometimes it's very difficult to implement. Although it is the fall now, a lot of these outbreaks and situations have occurred during the summer. It's extremely hot. People have to think about their personal health in addition to the need for the PPE. And so we do see a lot of breaches in PPE throughout that sort of situation. We have not seen sustained spread in mammals and humans, but we do need ongoing testing. So something that's been mentioned is routine testing or surveillance testing, as well as identifying persons with exposures that may be tested through a public health lab. So we can be prepared. Next slide. Next one. So speaking specifically in Georgia, but this applies to any state in the US, they're all doing this work. We have a multi-agency and years of HPAI response planning in Georgia under our belt. We work with a number of partners, including our Georgia Poultry Lab Network, which does quite a bit of testing, not only for sick birds, but also sick animals and otherwise. We also have state and federal agricultural partners, and then we also partner with academia on this sort of response. Next slide. So agriculture, one of the things we work on in our state is agriculture predominantly deals with animal health issues, and us in public health, we deal with human health issues. So what is the point of this response in particular is we need to work together. So we have actually put together quite a bit of education for our agricultural community and our human health community that is collaborative. And that is a really important part of addressing this in a united front. Next slide. We have a primary role of public health and monitoring persons. So this was mentioned in the previous presentation about persons that might have had exposure in another state. Those are reported to your state public health department, regardless of the state that you are in. Persons that are returning to that state that have been exposed to affected poultry or cows. in a response setting in another state. States will have monitoring systems set up. We have one of those in Georgia. It's in our state electronic notifiable disease surveillance system. We provide testing for H5N1 for those persons with symptoms, and an epi link or under a consult are determined to be of high interest or high index of suspicion for H5N1. We also work again with our ag colleagues to promote farm worker protection, and this is a screenshot of a educational flyer that was developed. Next slide. So we have also worked on additional efforts in 2024. So we have tailored messaging and communication materials for dairy and farm workers. We are also participating in the enhanced summer surveillance of flu specimens. This is the situation in which the Missouri case was identified. We've also increased our collaboration. As of actually today, updated to today, we have not had any dairy cow herds and no ongoing poultry outbreaks. Our last one was in 2023. Next slide. So we also, we're experienced in Georgia, and many of the states that you work in, if you're not in Georgia, are also experienced. We have had backyard flocks identified in Georgia. We've monitored over 130 exposed persons in Georgia. And again, a lot of those were exposed out of state. They were deployed to work on either cattle or poultry responses in other states. We have arranged for telemedicine consults and also in-person consults for folks that have reported influenza-like illness symptoms. What's really interesting for us is we have tested a number of people in Georgia, even with known exposure. And our most common positive result has been human rhinovirus. So we would expect COVID, we would expect maybe seasonal flu, but we've seen a lot of rhinovirus in these situations, which has been interesting. Next slide. So this is where we get to denominators. So one of the things I just wanted to point out is when we're talking about the general surveillance, this is not depicted on this slide, but when we're talking about those surveillance samples where we're doing enhanced surveillance of flu samples from Sentinel providers, there have been over 54,000 samples tested and only the one positive in Missouri identified. When we're talking about persons that have known exposure, so persons that have been on a farm, a cattle farm, a poultry, in an industry setting, commercial flock or backyard flock, and have a known exposure, we've monitored over 5,100 people just in 2024. At this point, as we've talked about previously, we have 27 confirmed positives and another 4, so up to 31 with the presumptive positives in Washington. But those denominators are really important for us to just consider the scope of this risk to human health. So right now, there's no need for increased testing in situations where we don't have an index of suspicion for H5N1. So we don't have someone with exposure. They're just maybe a person in the general population with respiratory disease. But we do want to help to inform those decision makings with you all as a partner, clinicians as a partner, if you do suspect H5N1 for a particular reason. Next slide. And we'll go through this very quickly because I know we're up on time. I know wastewater has been a very hot topic for this. H5 can be tested for in wastewater. We are actually testing in Georgia for influenza, and it may be a useful tool, but the source of H5 contribution is a sticking point for us. If we do detect H5, we don't know if it's people, if it's mammals, if it's birds. We know it's circulating in our wild bird population. So what do those H5 positives mean? We also have questions about threshold and whether or not it's an infectious virus. So there's a lot of things we know, but a lot of things we don't know about wastewater testing. Next slide. So one of the things we also consider is a lot of our agricultural businesses of concern may be on septic systems. This is the case in Georgia, but it's also the case in other states as well. And they may not contribute to municipal water systems where a lot of wastewater surveillance is done. We also know that it would likely take high levels of H5N1 to identify a spike in wastewater. When we're talking about anywhere between 5 and 200,000 persons or even more contributing to a wastewater sewer shed, it takes more than one person contributing to identify a positive. So we should just be cautious about overinterpretation as we're still learning. Next slide. Next slide. We'll skip through these for now, but happy to answer any questions about wastewater. In Georgia, we do have 14 of our 18 public health districts represented in our wastewater. Next slide. And keep going. So our key takeaways just for this is epidemiology and surveillance are the foundation for prevention and control recommendations. Again, we have robust monitoring systems for persons who have known exposure to these infected herds and poultry flocks. In Georgia, we have existing protocols, and in any state you're in, your public health departments will have existing protocols and strong partnerships with their Department of Agriculture and other partners in this response. And one of the things we always have come up in these questions about preparedness and response is, what do we do with this going forward? And so even if this situation does not worsen, even if we see these large denominators of persons monitored and we still see sporadic cases, this preparedness has overarching benefits for seasonal flu, pandemic flu, and also as we transition our COVID-19 response to a more pan-respiratory response with our other viral respiratory diseases. And that's it. Thank you.
Thank you so much, Dr. Feldpausch, Dr. Yecki, for those fantastic presentations. We have a little under 10 minutes now for some questions. And so I'm going to ask our panelists to keep their answers brief and succinct. But I want to also bring in Dr. Matt Lynham here, our resident clinical pediatrician. And Dr. Lynham, I'm curious, one of the questions has come in, how can we prepare hospital systems for something like this, hospital facilities? From your perspective, and especially from a pediatric perspective, what are some things that you and your teams have been thinking about at CHOA?
Yeah, that's a great question because, especially for things like H5N1, you don't, a travel question, have you traveled outside the country isn't necessarily going to flag on someone like this. One of the things that we've been trying to do at our points of entry, especially like our emergency departments and urgent cares, is to screen people literally as they cross the threshold. If they've got any respiratory symptoms, the child and those people accompanying the child are given a mask and asked to wear it. Obviously, there's some challenges with doing that when you have a child under the age of 2. But the other thing that we've actually moved towards is actually universal masking in our emergency departments and urgent cares, for everybody in our waiting rooms. And that's actually not so much related to kind of pathogenic flu or anything like that. It's just the amount of respiratory viruses and pertussis that we're seeing and trying to keep those people safe in our waiting rooms. So that's what I would suggest is making sure that you're catching people on the point of entry to EDs, emergency cares, clinics. And if they've got symptoms, if they're old enough and it's appropriate for them to wear a mask, have them wear a mask, and have those with accompanying them to wear a mask, just to try to protect those around you and try to catch those people that are symptomatic until you can get them, into a room and get more information like exposure to poultry or something like that.
Thank you for those points. A follow-up question to that. My understanding is, especially depending on the age of children, it's often very difficult sometimes to get them tested, especially in the emergency room for influenza or other respiratory viruses in general. Does that play a role in terms of, the approach here with potential H5N1? Say if we had patients who maybe were in California or had come from California, not of course global travel, but domestic travel.
Yeah, that's, one of the challenges is sort of that push-pull of trying to be good diagnostic stewards and not, send tests, for like respiratory, send like a respiratory viral pathogen panel on a child that you're not going to do anything with those results versus, having, doing testing and potentially having some surveillance. So it is challenging. Certainly not every child deserves with respiratory symptoms should have, a respiratory swab for testing. I think that's where history and physical come into play. Especially if you live in an area where there's a lot of agriculture, keeping the potential exposures, family exposures, like if there's a parent that works in poultry or dairy industry, and you've got a kid with respiratory symptoms and conjunctivitis and other people, that certainly would raise my concern. So, I think being thoughtful about testing.
I think that's a fantastic point, to be thoughtful about it and also to recognize the fact, I think you mentioned this earlier, especially in kids, diseases don't have to come from somewhere else. They can be present here in our own backyards. Really, we have to know the right questions to ask and how to properly identify them. Thank you for those points. I'm going to move now to Dr. Feldpausch. We've had several questions that have come in with regards to the types of testing, infection prevention, and hierarchy of controls that are in place or trying to be implemented at these agricultural facilities, poultry farms, and the like. Could you comment on that potentially? Besides PPE, what else are you all advocating for, and what other people might be doing?
Sure. I think something that's a really good situation for people to be aware of is the One Health approach to this. So we have regular meetings with our Department of Agriculture. They also include in these meetings a number of partners, federal, local. We also have, again, I'm going to speak to Georgia because that's where I'm at, but we have a very strong Georgia Poultry Federation with a president of that has been highly involved in this, but they were also very active in COVID-19 and protecting their workers during that time. It's a really robust industry. I'm speaking specifically to poultry, and I'll briefly mention our cattle industry. But we have regular meetings. There are recommendations from CDC and also from USDA. Those are being implemented. They are being messaged strongly. These industries have a high level of interest in protecting their workers and also their livelihoods in general. And we have also worked with our Cattlemen's Association in Georgia. We've met with them one-on-one in small groups with their president to talk through things like biosafety, the realities. Again, I know I talked about this during my presentation, but I think it's worth mentioning again. PPE, the recommendations versus the reality of implementing them on site in these scenarios there's a little bit of difference there. And they have been very, very keen on working with us closely to prioritize things that are going to be effective and efficient in preventing infection in their workers. And they are very, very excited to work with us on this. So, there's a lot of good recommendations from CDC, USDA, and again, they are also getting this from the agricultural side as well.
Fantastic. Thank you so much for that. And Dr. Lynham, back to you, because to play off what Dr. Feldpausch just mentioned, messaging in humans, messaging in the pediatric population, the families. I'm curious as to your thoughts on that. We've just heard about messaging and developing relationships with poultry farm workers, et cetera. But do you see any differences or important points to think about when you're talking with families and the hospital side?
A couple of things that I would, we know that like seasonal influenza vaccine doesn't prevent you from getting, H5N1, but I think there is the importance of encouraging influenza vaccination amongst, children, adults. The last thing we want is someone to, become a vessel for viral mixing between, flu strains and sort of really make things more complicated with a resortant virus. So certainly continue to push flu vaccine for seasonal flu, but there may be some additional benefits. The other is that this is another great reason not to drink raw milk. And I think this is another thing that we can, especially as pediatricians, make sure that we're continuing to, sort of impress upon our families who I think there's this growing push that raw milk is somehow better. And I think there's been high concentrations of H5N1 identified in milk of infected dairy cattle. So, that's another reason not to drink raw milk.
That's a great point. Dr. Yecki, in the closing few minutes here, a question for you based on what Dr. Lynham has brought up, the question of vaccination. Can you provide us with a potential update on whether or not we have an H5N1 vaccine? Would we see an H5N1 vaccine?
So there are candidate vaccine viruses that are well matched to the virus that is circulating among dairy cattle. It's this clade 2344B genotype B3.13 virus. And similarly, we have candidate vaccine viruses that would be a good match for the H5N1 viruses circulating among poultry, causing these different poultry outbreaks. There are no available H5N1 vaccines for use for anybody right now. If there were signs that the virus had evolved, if we had epidemiologic signs that there were a lot more cases, that there was an increase in transmission from animals to people and from people, to close contacts, accompanied by changes in the virus suggesting, a pandemic, we might be on our way to a pandemic, then certainly these candidate vaccine viruses could go into production. Now, there are stockpiled vaccines in the Strategic National Stockpile. It's the virtual vaccine stockpile that could be utilized, that could be deployed for studies. But right now, there's no indication that there's a need for this. There's certainly been discussions about using H5N1 vaccines for occupational exposed persons. That is not anything that's moving forward at this point. So I guess the reassuring thing is, as part of ongoing pandemic preparedness, my colleagues and colleagues worldwide are always trying to develop these candidate vaccine viruses, because these viruses are all evolving as they spread among animals, and they could change. So whether or not they're ever used in people, I can't say, but we do have candidate vaccine viruses that have been shared with manufacturers that could go into production if needed. And as Dr. Feldpash has mentioned, there's no signs that we're in a pandemic situation. A pandemic is not imminent. Of course, that could change in the future. That's unpredictable. There's many other novel influenza A viruses that have infected people of avian or swine origin worldwide. So H5N1 is not the only pandemic influenza threat. And actually, we have candidate vaccine viruses against many of these other novel influenza A virus threats. So we, again, a lot of attention on H5N1, and justly so, but it's not the only virus of pandemic potential. Thanks.
All right, fantastic. And then with those words, we are going to end our discussion. I want to say thank you so much to our panelists, to our audience for participating. Before we close, I'd like to again just pose one more interactive question after participating in this session for the audience. It should be on your screen. How knowledgeable do you feel about the current state of H5N1 and now the management of a suspect or confirmed human case? If you could please vote now. While we're getting a few seconds for that, I just want to say thank you again to everyone. Thank you to our technical team here at the SCDP ECHO, Yasmin Thornton, our Project ECHO coordinator and leader extraordinaire, our planning committee with Sharon Van Arsdale, Anish Mehta, and Allison Claybar. Thank you. If we could get the poll responses up on the board, please, or on the screen. It looks like our panelists have made some significant inroads, so I want to applaud them. I want to applaud the audience. Everyone is now at least possessing some knowledge about H5N1, which is absolutely fantastic. So for feedback and further information, including continuing education credits and the recording, please check the website and the links here. We look forward to seeing you again soon. Take care.